Jyoti, am I audible?
Yes, sir.
Okay. Share your screen. We will start at 9:05.
Okay.
Jyoti, we will start in at 9:05. Another 1 minute to begin.
Okay, sir.
Over to you. Jyoti, you can start now.
Yes. Good evening, everyone. Today we are discussing about the journal club. The topic of the journal club is a modified lung ultrasound score to evaluate short-term clinical outcomes of bronchopulmonary dysplasia. And the content we are going to see is publication details, background on lung ultrasound and lung ultrasound scores, need for modified lung ultrasound score, materials and methods used, understanding the basic of ROC curve, and results of the article, conclusion, and critical appraisal of the article. So this article is published in BMC Pulmonary Medicine on 19th March 2022 with the impact factor of 3.317. And let's see the some basics of lung ultrasound, which is used in assessing the severity of lung diseases without any radiation exposure. So there is little data on the lung ultrasound for evaluating the BPD and its short-term clinical outcomes. And as we know, with the increase in survival of the premature babies, there is increase in incidence of new BPD also. So recent articles showing 1/4 of like 25% incidence of BPD in premature babies less than 1.5 kg. And based on the previous evidences, the lung ultrasound has been now recommended in the European point of care ultrasound guidelines also in NICU and PICUs. And the previous studies on lung ultrasound BPD have classical lung ultrasound scoring to predict the diagnosis of BPD. For lung ultrasound, we use probes like a hockey stick probe, linear probe, curvilinear probe, in which hockey stick probe will be better than linear and then curvilinear. So higher the frequency and of the probe, better will be the picture quality. The regions which we are going to see in lung ultrasound are anteriorly right, upper anterior, lower anterior, then laterally upper and lower part, and posteriorly upper and lower part of the lung. This is 12 region approach. So 1, 2, 3, 4, posteriorly 5, 6, and both sides 12 approach. And 6 region approach is only the anterior, upper and lower part, and the lateral part on each side. So total 6 region approach. The position of the probe we keep in a perpendicular to the ribs, and another position is parallel to the ribs. That is parallel probe positioning. And some basic terminologies used in lung ultrasound are pleural lines, which are seen like thin, smooth, regular lines, hyperechoic, which indicate the parietal pleura, and the similar lines seen below the pleural lines, which are echoic, horizontal, and parallel lines, which seen like a bamboo sign. And lung sliding is when pleura moves synchronously to and fro with the respiration. That is seen in the video. As this is still image, we can't see the lung sliding, that I'll show in the last part. And the B lines, which arises from the pleural lines, and these are vertical laser-like hyperechoic, which are present at the air-liquid interface, and these are seen normally till 24 to 36 hours of life, as the lung fluid takes time to get reabsorbed. And the B lines of different types, these are simple B lines, and the confluent B lines are B lines covering the entire intercostal space with the rib shadow seen in between. And compact B lines are the lines representing the fused confluent B lines with no rib shadows. And alveolar interstitial syndrome means the confluent B lines present all over the lung field, and when the compact B lines are present all over the lung field, they are called whiteout lung. And consolidation is seen on lung ultrasound like a lever consistency, as you can see here. The classical lung ultrasound score is can be written in this way: the A lines, B lines, lung sliding, consolidation, pleural effusion, whichever is present in the right upper, lower, right lateral, or left upper, lower, and left lateral regions, we have to write the score. The score 0 will be only A lines with the lung sliding present and no B lines. Score 1 will be more than or equal to well-spaced B lines. A lines may be present or absent, and lung sliding will be present with no consolidation and pleural effusion. Score 2 is given for severe B pattern, which is confluent or compact B lines, and subpleural consolidation less than 1 centimeter, which is not an essential criteria, and no extensive consolidation and pleural effusion. And score 3 is given for extensive consolidation more than 1 centimeter with or without pleural effusion. And these are the regions studied in the classical lung ultrasound score: right upper lateral lower and left upper lateral lower, 6 region approach. In modified lung ultrasound score, they used 2 additional views. One is a transhepatic lung based ultrasound, and second is a transsplenic lung based ultrasound, which is called as a retrohepatic and retrosplenic view. And when we do the modified lung ultrasound score, we use the convex probe, which is kept below the lower end of the ribs in a sagittal plane above the liver and spleen. And the upscan is performed to visualize the lung base. And the scores are given as we have seen before. In modified lung ultrasound score, the 6 chest areas of classical lung ultrasound were used, plus 2 additional. So total 4 per slide, and the score will be 0 to 24. As seen in this is in classical lung ultrasound, we score it as a 0, 1, 2, and 3. And in retrohepatic lung USG view, the upper part is seen, which is liver, and this is a diaphragm, and below that is lung field. So in 0, there will be a normal lung field. In 1, there will be B lines, and 2 compact or confluent B lines, and 3rd, we can see the lung consolidation also. In BPD patient, the lung lesions of the BPD patient may be, why this modified lung ultrasound score is important, because in classical lung ultrasound, they have used only anterior and lateral part. And as we know, the BPD lesions can be present or more significantly present in the posterior and lower part of the lung. So that area must be seen, which is not seen in the classical lung ultrasound score. And so let's see the go to the article part. They have hypothesized that modified lung ultrasound score correlates well with the short-term clinical outcome and has a better diagnostic value in preterm infants compared to classical lung ultrasound. They use the population of preterms with less than 34-week gestation, which were admitted in NICU before 28 days of life in Children's Hospital of Fudan University. And the modified lung ultrasound score was done at 36 weeks of post-menstrual age and was compared with the classical lung ultrasound score for assessing the BPD by correlating the score with the modified NICHD classification of the BPD. And their outcome first was correlation between the modified lung ultrasound and short-term clinical outcome. And the second was comparison of clinical outcome of BPD based on the modified lung ultrasound to conventional lung ultrasound USG. And this study was prospective diagnostic accuracy study. The exclusion criteria they used were severe congenital heart disease, major congenital abnormalities, chromosomal abnormalities, suspected muscular dystrophy and neurological diseases, and those babies who had death or transfer before 36 weeks of post-menstrual age. And the machine they used was Wolfson TM Pro ultrasound machine with a linear and curvilinear convex probe. In modified lung ultrasound score, as we saw before, the classical 6 views plus 2 additional views were used with the 4 per side and the score of 0 to 24. And they recorded these chest areas and they analyzed with the 2 investigators which were expert in the lung ultrasound and were blinded for the clinical condition. So this statistical part will be explained by Dr. Arjun sir. Over to you, sir.
Am I audible?
Yes, sir.
Yeah, okay. So we will be discussing the statistical part. I will be explaining it. Thank you, Jyoti. Till now, you have been excellent in presenting the part. So basically, for this study, since there are 2 different, since USG is an observer-dependent issue, so that's why 2 independent investigators were taken and they were blinded. Still, they wanted to make sure that there is proper absence of inter-observer variation. So for that, what they did was they did an intra-subjective coefficient of variation, that is standard deviation by mean. So what they did was, for the standard deviation, they took the standard deviation of the measured differences between the two investigators, and the mean taken as a denominator was mean of all the measurements. Based on this, at the end, in the results, we will discuss the intra-subjective coefficient of variation. Next slide. Jyoti, please, next slide. Yeah. PhD, NHLBI severity, then they discuss the respiratory support, the oxygen requirement, the postnatal steroids, the duration of mechanical ventilation, duration of supplemental oxygen, and length of hospital stay. Next slide, please. Next slide, please. So based upon what they used was NICHD, NHLBI definition of BPD severity, and on that basis they had calculated what they did was, Jyoti, please don't skip the slides. Go back to 2 slides back. So what they did was non-BPD, mild BPD, moderate and severe BPD based upon the O2 requirement and based upon the ventilation requirement. I know many of you must be wondering, this is the old classification of BPD that was used in 2000, that was built up in 2001. And nowadays the Jensen's classification is being used and physiological based BPD definitions are being brought up, and NICHD 2018. But that was the major drawback of this study, where they used only the 2001 BPD severity. Next slide. So the outcomes of the study, basically what they studied was the correlation between the modified lung ultrasound and the short-term clinical outcomes. And the next thing was the evaluate comparing the modified lung ultrasound to the conventional lung ultrasound, as rightly explained in the previous slides. Next, please. So coming to the statistical analysis. Next. So for the statistical part of this study, first of all, let's discuss the sample size calculation. The sample size, for that, they took a target of area under curve of 0.7 on the ROC curve. And as we all know, the basics of ROC, the null hypothesis would be an area under curve of 0.5. The alpha error taken was 0.05 and the beta error was 0.1. And on that basis, the statistician calculated 82 participants would be required for the above specification. Next. So now for the continuous variables, they use mean plus minus standard deviation, and for the categorical variable, they use the percentage. Now in this study, there is a figure you can see, all of you can see on your computer screen. So what was happened is that the study population was a not non-normally distributed study. At the end, what they found out was the study was not normally distributed, and since it was the same population, that is, those babies who were less than 34 weeks of gestation admitted before 28 days, they were enrolled. So we created two groups from the same population. One group was those same babies who had undergone modified lung ultrasound, and the same baby had undergone the conventional lung ultrasound. And then we are comparing. So basically, there are no two different populations. They're the same population from which we have created two different groups. I hope I'm able to make you understand. And since the data was not normally distributed, that's why the Wilcoxon single rank sum test was used in this study. Next slide. Next slide, please. Yeah, and for the comparison of the modified lung ultrasound and conventional or the classical lung ultrasound, they use the Spearman's correlation and regression coefficient, and they use ROC curve to define the ability of the lung ultrasound and modified lung ultrasound for that matter in diagnosing the short-term clinical outcomes. And finally, with the help of the ROC curve also, they tried to calculate the best cutoff for the modified lung ultrasound score in order to define the moderate and the severe BPD and also the severe BPD. And they also use the Jordan's index for the calculation. Next. So let's discuss the statistical part of this article. Before that, I need you all to concentrate on the diagnostic accuracy of the test. This is very important. And for all the DM and the DNB candidates, this can be asked as a 10-mark question. This can be asked as a long question. This can be asked in the short questions. So many n number of short questions can be built up from this topic. That's why I have taken up. We will discuss lung ultrasound. I know that must be interesting. That must be giving you a lot of excitement about lung ultrasound, but on the same hand, we have to be strict to the basics also. So let's discuss the statistics. So next slide. Next slide. Yeah. So all of us have been very well aware of this table. We have seen in our MBBS, we have seen in the MD. So what is this 2 into 2 contingency table? Here on the column side, there's a disease present or absent, and on the row side, it is the test results present or positive or negative. So we all know what is true positive, what is false positive, what is false negative, what is true negative. So sensitivity is nothing but true positive with the denominator of true positive plus false negative. Specificity is true negative divided by true negative plus false positive. And positive predictable value is basically true positive divided by true positive plus false positive. And negative predictable value would be true negative divided by true negative plus false negative. One piece of advice to all the residents is, please go back to the previous slide. Jyoti, go back to the previous slide. Okay, fine. So basically what is there is please don't mark with A, B, and C and D, and don't get confused with A, B, C, and D. You understand the concept. To understand the concept, let's go to the next slide. Jyoti, forward, next slide, please. Yeah. So what is sensitivity? Sensitivity basically is probability that an individual with a disease will have a positive test. That means if I am suffering from some disease, what is the probability of this XYZ test to be positive? Understood? So, for example, if in the COVID era, when we were doing RT-PCR, so if I am suffering from COVID, what is the probability of the RT-PCR to be positive? That is called a sensitivity. Next slide. Next slide, please. So specificity, Jyoti, next slide. Yeah, the specificity is basically the true negative rate. So what does the true negative rate means? Probability of a disease-free individual to have a negative test. Suppose if I'm not suffering from COVID, what is the probability of the RT-PCR to be negative? That is called as specificity. That is called as true negative rate. Next slide. So in this, I hope you got some idea of sensitivity and specificity. These two tests are the properties of the test. They are independent of the disease prevalence, and they are the ones that accurately diagnose and evaluate and discriminate between an individual with a disease and without the disease. Next slide. Next slide. Yeah. So another important point that you need to remember is what is snout and what is spin. Now, this is a very common mnemonic which is being used, and it is very important mnemonic to be understood. So what is snout? Snout is basically sensitivity and out. That means sensitivity, if negative, will rule out a disease. Best example I can give is of rat and RT-PCR. Now, whenever we were suspecting COVID, we used to send rapid antigen test. And based on rapid antigen test, we used to do whether we need to do COVID RT-PCR or not. So what is rapid antigen test here? It's a test with a good amount of sensitivity, but not a very good specificity. That's why when it is positive, we still need to confirm it with a good specific test. But if it is negative, then we can rule out most likely that the baby or the child is not suffering from COVID. Or in other words, any test with a good sensitivity will be able to rule out the disease at the onset. In order to confirm if the sensitivity test is positive, then we cannot rule out a disease. So for confirming, we need a test with a good specificity. The good specificity will help us in building a confidence in diagnosing that this disease, the patient is suffering from this disease, if that test has a good specificity. So that's why spin and snout, two things, please remember. Next slide. Now coming to ROC curve. Till now we have discussed sensitivity and specificity. What sensitivity and specificity are being used in is basically whenever you have a test with which is not having a continuous measurement, like whether the answer to a question or answer to a report is positive or negative, yes or no. But in conditions where the test is not giving an answer in terms of yes or no, and it is giving the answer in terms of a continuous measurement, when for example CRP. Now CRP cannot be positive and negative if we are doing a quantitative CRP. So quantitative CRP can be anything between 1 to 100, or it can be 200. Anything can come, any number can come. So when you want to assess a diagnostic test which has a continuous measurement, then ROC curves are used. So very important is to understand what is the cutoff values and what is the relation of cutoff values to sensitivity and specificity. We have discussed the CRP and in this slides, and we all know the CRP has a definitive cutoff. When we say the CRP is 4 or 5, we say that this is negative. When we say CRP is 40, oh, this is positive. So definitely somewhere there is a cutoff from below which we are saying it is negative, below which we are saying positive. Let's understand what happens with the cutoff to the sensitivity and specificity. Next slide. So what happens is that whenever we suppose we have a baby with a CRP of 10, and we for the benchmark keep the CRP as 10 as the cutoff for bacterial sepsis, just a hypothetical one. We are not challenging any scientific basis. So we are just trying to explain what is the meaning of sensitivity. So suppose if the baby has a CRP of 40, so definitely that is positive. Now, if I increase the cutoff value, if I increase the cutoff value of CRP to call it as positive, I increase it to 30. So those babies between 10 and 30, those who might be positive for bacterial sepsis, we will regard them as negative. So what we are doing is we are decreasing the sensitivity. But definitely, if we are saying positive for the test with a very high CRP, definitely they will be suffering from some bacterial sepsis or some kind of inflammation. So there will be increase in the specificity. Similarly, if I come down on the cutoff, I will increase the sensitivity. I will diagnose more cases being positive for sepsis, but I will reduce the specificity. Those babies may not actually be septic. They might be having just some amount of inflammation because of which CRP is borderline increased. So see how does the cutoff changing of the cutoff changes the sensitivity and the specificity. Next slide. So let's come to the ROC. So ROC curve, as I told you, it is a plot that evaluates a diagnostic test and represents a continuous variable among the disease and the non-diseased. So ROC curve is very much often utilized to know a cutoff for a diagnostic test that will provide the maximum sensitivity and specificity, which will help in ruling in or ruling out the disease. That depends upon what we are looking at. Next slide. So in this curve, this is the classical ROC curve. On this ROC curve, there are 4 points that you need to remember. The x-axis is 1 minus specificity. The y-axis is sensitivity. So x-axis is the one which is the false positive rate, and the y-axis is the one which is the true positive rate. In between, there is a line which is called as a line of equality, which is joining the point A to point C. What does this line of equality says? Any test which has an area under curve less than the line of equality, or if we plot on the points and if those points fall below the line of the equality, then that means the diagnostic test has no relevance to differentiate a disease positive from a disease negative. Understood? So at the A point, the sensitivity will be 0 and the specificity will be 100%. At the B point, both sensitivity and specificity will be 100%. At the C point, the sensitivity will be 100%, but specificity will be 0. And at the D point, both sensitivity and specificity will be 0. So D point is the worst, B point is the best. Okay. And these curves are plotted between 0 to 1 on the x-axis as well as 0 on the y-axis. Next slide. Next slide. So how do we draw the ROC curve? So we have used the CRP. Suppose we have done for 200 patients the CRP and we have found out these values 26, 28, 22, 18, 19. Please go back to the previous slide. Jyoti, please go back to previous slides. You're jumping the slides. Yeah, hold on this slide. So when the CRP is 26, 28, 22, 18, 19 in this form, we have calculated the CRP for 200 patients. Now, for the first time, we will take the cutoff of the CRP as 10 milligram per liter. And based on that cutoff, we will define the blood culture positive cases and blood culture negative cases, and we will define the sensitivity and the specificity. Next slide. Similarly, for the CRP of 20, we'll take a cutoff of 20 and then we will again define the sensitivity and specificity. Now for 30 and now similarly for 40. Like that, for the CRP of 10, 20, 30 and 40, we will define the sensitivity of a blood culture positivity and specificity of blood culture positivity. And then we will plot these points on the ROC curve. Like what, when suppose the CRP is 10, what is the sensitivity? 0.75. So we will on the x-axis plot 0.75 and 1 minus specificity will be 0.44. So we will plot 0.44. Similarly, we will make the dots at 20, at 30 and at 40. And then we will join all these dots to produce a curve which is called as the ROC curve. Next slide. Now, how do we interpret this ROC curve? The most important characteristic of an ROC curve is the area under curve. Now, what does the area under curve means? Area under curve means the entire area which is there from the point A to C with the curve. So, in this previous example, the area under curve came 0.755. So that means it is a good area under curve. Any area under curve which is more than 0.5 is considered to be good, but an area under curve of 1 will be the best. That means the point will be touching the B point. The curve will be touching the B point. When the curve is touching the B point, that means that the test has 100% sensitivity and 100% specificity. That would be obviously the best test. But in ideal situations, we never get the best test. What we get is somewhere around 80, 90, 95, 96. So we will be very close to the point B. Next slide. Next slide. Yeah, so area under curve is a measure of accuracy of the diagnostic test. As I told you, the left upper corner, the B point, concentrate on the B point. If a curve is touching the B point, then the area under curve is 1. That means that test has 100% sensitivity and specificity. And if the curve is very close to the line of equality, that means the area under curve will be 0.5. That means that test is least accurate. Next slide. Next slide. So next, other important thing is to find out the optimal cutoff. So there are two ways to find out the optimal cutoff. So on your screen, can you see this is the ROC curve? So to find out which cutoff, suppose we have the CRP here, CRP was 10, here CRP was 20, here CRP was 30, here CRP was 40. Now, what we need to find out is the cutoff, which would be the cutoff for the test, is to call it as positive, to call it as negative. For that, the first point is the D point. First method is a D method. So what is D? D is the line which is joining the point B to the point curve. Now, as I told you, closer the curve is towards the point B, it will be better test. So you can very well guess that smaller the D, smaller this D, better will be the test. Higher will be the sensitivity, higher will be the specificity. That is one way of assessing the optimal cutoff. So the point from B, if I draw a line towards the curve, the shortest distance will give me the maximum sensitivity and specificity possible for that test, and that point would be the cutoff. Suppose if the CRP was 20 and CRP was 30 here, so my CRP cutoff would be 25, somewhere between 20 and 30. That the machine will give, that the software is the one that gives the cutoff. Next slide. The second way of understanding the ROC curve for optimal cutoff is the Jordan's index. Now, just inversely to the D point, just imagine if I draw a perpendicular line from the curve towards the line of equality, and I draw these lines specifically all over the curve, I need to identify where my Jordan's index is maximum. So wherever the Jordan's index is maximum, that would be the cutoff for calling the test to be having the maximum sensitivity and specificity. Understood? So D should be minimum and the Jordan's index should be maximum. When the Jordan's index is maximum, when the point where the Jordan's index is touching the curve, that is the cutoff, and that is the cutoff, and that cutoff will ensure a maximum sensitivity and specificity possible for the test in diagnosing the disease. I hope I am quite, I tried to do a sincere effort to make you understand. Still, if some doubts, you can tell me at the end of the seminar. Moving to next slide. Jyoti, next slide. Next slide, please. Next slide. Yeah, another important part of the ROC curve is to understand the difference between the various tests. So we can diagnose, we can assess one test At the same time, we can assess multiple tests with the ROC curve. We will draw the same we will draw on the same box all the possible ROC curves for the test like A, B, and C. There are 3 tests to diagnose a disease. Okay, so test A is there, test B is there, test C is there. Now you can see that the test A is having a ROC area under curve like this. Test B will have a larger area under curve, and can you see test C has a further larger area under curve than the test A and B. That means the test C is the best test to understand, to increase the sensitivity and specificity in diagnosing a disease. That's how we can compare the various tests. And let's discuss the modified lung ultrasound score and classical lung ultrasound score on the ROC curve. So over to you, Jyoti. Please continue the journal club part of the article. Okay, continue to the next slide, please.
So results of the article are like between January 2017 and December 2019, 166 eligible preterm babies were admitted in NICU, in which 38 were excluded and 128 infants were finally enrolled in the cohort, and they were classified in no BPD, mild BPD, and moderate and severe BPD. And the demographic characteristic of the study population used was like this, with the inverse correlation with the gestational age and birth weight. As the severity of the BPD increases, the correlation, like lower is the gestation, more is the chances of severe BPD, with the p-value, significant p-value of less than 0.001. And also with the APGAR score at 5 minutes and PDA treatment has also the significant correlation. And postnatal steroid and respiratory support at 40 weeks of postmenstrual age and length of the hospital stay is also correlated significantly with the significant p-value. So the result of modified lung ultrasound score for whole cohort was 14 with a interquartile range of 8 and 17, and those subject with the BPD had modified lung ultrasound score of 16 with interquartile range of 6 and 17, and subject without BPD had a score of 3 with interquartile range of 1 and 6. As we have discussed previously, that they have calculated the inter-subject coefficient of variation, which come out to be 3%, which of suggestive of the very good consistency of between the two investigators. And in this slide, you can see clearly on the x-axis, the NICHD classification, non-BPD, mild BPD, moderate BPD, and severe BPD is given, and the y-axis modified lung ultrasound score is given. And you can see in this, the box and whisker plot is used. Classically, see that the average score of non-BPD modified lung ultrasound score was only between 3 to 4. And as we go from mild to moderate to severe BPD, the increase in the modified lung ultrasound score, and the result had good significant p-value of less than 0.001. And here we see